Hello, my name is Allison and I'm the pharmacist here at the Nebraska Heart Institute. I'm in charge of running the anticoagulation clinic, and today we are going to be talking about the new oral anticoagulants and also doing a quick review about Warfarin. So talking about the risks and the benefits of blood thinning. So our objectives today, hopefully after this talk you will be able to better recognize the indications for these medications. Know the dosing for each drug, at least the most common form. Understand which side effects that the patients should be looking out for, which ones are common, which ones we should be concerned with. Look to see what laboratory tests we need to run and how often. And then know whether or not there's major food or drug interactions with these medications. We'll also be talking about the cost difference between Warfarin and the new novel agents. And also hopefully you'll be able to utilize the educational packets and know the main highlighting points that you should be talking to the patients with. So first we're going to talk about Warfarin, or Coumadin. It's a vitamin K antagonist. Vitamin K plays an important role in our clotting system because vitamin K is turned into our clotting factors 2, 7, 9, and 10. It also helps with our anticoagulant proteins C and S. So what Warfarin does is it competitively inhibits the enzyme which activates the vitamin K, turning them into those clotting factors. It also helps deplete the vitamin K reserves in the body, and so the end result is our body doesn't have as many clotting factors, making our blood what we commonly refer to as thinner. The nice thing with Warfarin is that whether it's brand name or generic, as you can see along the bottom, that's the same color no matter who makes it. So if the patient's not familiar with what their strength of their medication is, it is nice to know that what color it is, because depending on color you'll be able to identify what strength. So if the patient can't remember the strength, make sure that they remember the color. So like I said earlier, our clotting factor cascade, this nice picture of our cascade, and Warfarin kind of hits all over this cascade. That's why it takes 5 to 7 days to see the full effect. Each of these different factors has a different turnaround time to be made, and some of them take a little bit longer, so we won't see that full effect for 5 to 7 days. So why do we use Warfarin? Warfarin is used for the treatment and prevention of a DVT or PE in patients who have had an acute episode. It's also DVT prophylaxis for patients who are going under some type of orthopedic surgery. Also, our main reason that you're going to see patients on this is to prevent some type of thrombic event when they have atrial fibrillation. So a stroke is our big one that we're really worried about with AFib, and so that's why we're trying to prevent that by thinning out their blood. We also have prophylaxis of arterial or venous thromboembolism and antiphospholipid antibody syndrome. It's more of a rare disease, but we can see that. And the newest one here at Nebraska Heart is for our LVAD patients. We use this because they're at a higher risk for clotting with the type of machines that they now have in them, and so we don't want to have them develop a clot in their new heart. So our dosing for Warfarin is patient specific. There's no nice dosing, you're on it for this reason, you're going to take this dose. Like most of our medications, it is very patient specific depending on how they metabolize the medication and what their diet is like. And also why we're using this medication. So we dose to treat an INR. Most of our INR goal ranges are going to be 2 to 3. That's our typical INR for our patients. These include our AFib patients. If the patient has a mechanical heart valve, then our patient is going to have a higher INR range, 2.5 to 3.5, because the blood likes to stick a little bit more to that mechanical valve, and so we want to make sure that since they're at a higher risk, their blood's a little bit thinner. Our LVAD patients are a little bit lower than typical, so they're a 1.5 to 3.5 for the majority of the time. So I know it's a lot of different numbers to remember, but just remember that it is patient specific. The nice thing with warfarin is there is no dosing adjustments needed, so it does not depend on the patient's renal function or kidney function, so we don't have to adjust and look at those things. So the biggest thing here with our side effects is our bleed risk. We're taking away our patients' clotting factors. We're not allowing them their body's natural ability to stop bleeding if something were to happen. So our biggest side effect is that increased risk of bleed. Most patients tolerate this really well, and as long as the patients stay within their goal INR range, it's not something that most patients experience. It's once they get too much warfarin on board is when we start to be concerned. Some more rare side effects is a skin necrosis. It is less than 0.1%. Some people also call it purple toe because it typically develops in the foot, on the big toe. There have been some people who have also developed a rash, but that's usually right when they start the therapy, not if they've been on it for a while. Most patients can tolerate it at that point. They have been noticing that there's some bone fractures with long-term use, and this is over a year, but it's not something that we're concerned about at this point in time. Warfarin has a long history of success in this patient population, and so the benefits of preventing that stroke and that DVT outweigh the risk of the bone fracture, so that's not something we want to frighten our patients with. With warfarin, there is an antidote that is available, so there's something that can reverse the effects of warfarin if something were to happen and the patient was in a traumatic situation. Those include vitamin K, and they also have a prothrombin complex that we can give that has the nice, all those different clotting factors in it. We can also give fresh frozen plasma for symptomatic support as well. Warfarin is the only anticoagulant on the market that has a true antidote to it. The other novels do not currently. So warfarin is a drug we love to hate. We love it because it does its job so well. We hate it because it interacts with everything, including food. And so I'm just going to take a little bit of time to mention the big drug interactions that we should be kind of knowing and looking out for when patients come in and we talk to them about their medications. So there's many medications that warfarin interacts with. Our big ones are going to be our antibiotics. It's something that is known to cause the INR to increase and make the blood thinner. So it's really important that the patients understand that anytime that they start or stop a medication, they need to inform their managing provider. The other ones that are cardiac specific is also amiodarone. Amiodarone is also known to increase the INR. We have to play around with the warfarin. It needs to be checked more often. This also, when they stop or start a medication, it also includes things that they're not thinking about, which are their home medications from the pharmacy. So over-the-counters, herbals, and vitamins also. Warfarin is our medication that we have to worry about food. And it's not all food, but the patient does need to be aware of how much vitamin K they are taking in each week. It's not something that they have to write and take down a diary for each day, but be a little bit more conscious of what types of foods they're eating and making sure they're eating the same types throughout the week, so that way their diet is consistent in that vitamin K. Now, what is vitamin K in our food? Vitamin K can only be digested from food. Our bodies do not naturally make it. And our general rule of thumb is if it comes from Mother Nature and it's green, it has vitamin K. So any type of green vegetable, nut, or fruit will have vitamin K in it. Or the darker the green, the more vitamin K is in our food. There are some foods that are sneaky that patients don't realize that there's vitamin K in there. So the main example is store-bought mayonnaise. A lot of people like to put mayonnaise on their food during the summer times because there's all those picnics and pasta salads and potato salads, and that's when we typically see fluctuations in the INR. The patient isn't really realizing it's their mayonnaise. So there's multiple different websites that are out there for patients to utilize if they're not sure what type of foods they need to be being consistent with. Just remind your patients that they don't have to stay away from these foods, but it's just important to make sure that they're consistent with the amounts each week. So what do we monitor? What do we look for when we're making sure these patients are being safe with this med? For warfarin, we use the International Normalized Ratio, or the INR. It's just a fancy speak for adjusting everybody's pro time to a standard number. Each pro time is a little off, and so the INR is just something that we can all talk about equally, no matter where they get their lab drawn. Again, our INR goes anywhere from 2 to 3, 2.5 to 3.5, or 1.5 to 2.5, depending on the indication as to why the patient's on the warfarin. The cost of warfarin, it's actually pretty cheap. It's been around forever. Patients can still get brand name, but most people do get the generic warfarin. So usually it's going to be on that $4 list for Walmart or other pharmacies that are equal to that, but it's also about $55 cash price for 100 tablets. So not too bad out of pocket. Most insurance companies, it is a tier 1 generic copay, so not too bad for out-of-pocket costs for our patients. One thing that they do need to consider with the cost of warfarin is not only the medication, but the cost of monthly testing, or if something were to go wrong with their INR, more frequent than that. The nice thing with warfarin, there are a couple of companies that do home testing as well, and so that would also be something that they need to keep in consideration for the cost of per month. So for our warfarin teaching is a little bit more involved. The slide shows you some main talking points here. The main thing is going to be, taking it at the same time each day. It's going to be recommended with the evening meal. It's preferably in the evening. That way if they have their INR appointment and we need to make adjustments, we can make adjustments that day and not need to make them in a different, or the next day. Again, just reminding them to be consistent with their diet. Their diet is a large part of their INR, and so patients may need to get used to being a little bit more conscious of what they're eating. Remind them of the importance of making sure that they're keeping their INR appointments and not going an extended amount of time between appointments. It's a great medication. Most patients are able to get stabilized within their range and just go out to that monthly appointment, but some people go on beyond that month, and that's when we start getting worried about them. Make sure that they talk to their any of their providers, including dentists, to let them know that they have been started on this medication. Recommended to fill all their medications at the same pharmacy. That way the pharmacist can keep an eye out for any time that they have a different provider prescribe another medication, making sure that it's not interacting with their warfarin. So with that, I know there's some more common signs and symptoms of bruising and bleeding, but we'll talk about that with the next slide. We put together a nice packet here. The red is for warfarin. If you're here within the Lincoln campus, you can use, we'll be giving you packets with the anticoagulation clinic's phone number. That way the patient has that if they have any questions, whether or not they're being managed by NHI, they can still utilize this as a resource. So in our packet, we have some different forms that should be filled out. This is an enrollment form for the patient to be actually eligible to be managed by NHI. It just gives the patient's name, date of birth, and why they're using it and what their target range is. It does need to be signed by the doctor who is their cardiologist, saying, yes, I want my patient managed by the clinic. We also have a teaching checklist. I know there's a lot of information, so we made you a nice little checklist to make sure that we hit the majority of the points for this. The patient also does sign this, that way they're taking a little bit more responsibility for their health and making sure that they are aware of that, yes, we did talk to them about this medication. So the first thing that you're going to see underneath these forms is going to be this anticoagulation packet. It just is going to be a lot of that information that we've already talked about. What is an anticoagulant? Why are they taking it? What are your therapeutic ranges? What to look out for? When to be concerned? That type of thing. You don't need to like read this line by line with the patient, because this is going to go home with them, and it could be a good resource. That way if they have questions at their next appointment, they can ask. On the other side of the folder is going to be all these papers. The first one is our common signs and symptoms of bleeding. This you're going to notice is in every single packet because each medication has the same risks involved with it, and it's also preventing the same thing. We're preventing those clots. So the majority of our medications are going to cause minor bleeding because we are thinning their blood. Patients might notice that if their gums may bleed when they use a hard bristle toothbrush. One way to help them manage that is recommending a soft bristle toothbrush. They may notice that they're bruising a little bit more easier if they like walk by something and they hit their hand on it. They're going to notice that they're probably going to bruise where before they were not when that happened. Minor bruising is okay. I know, make sure that they are aware that it's okay. They will go away. They're going to just take a little bit longer to heal than normal. With these, they'll also notice that they might be a little bit easier to have a nosebleed. That's because, especially during the winter time, the air is a little bit more dry, which means our nasal passages are drier. So recommending using saline, a nasal saline, help to keep those nasal passages moisturized. It's going to help reduce that risk of a nosebleed. So those are more of our common signs, or common bleeds. They're not ones that need to be really concerned about. They might be a little disturbing to the patient because they're not used to it, but it's not time to call. The time to call is when they have a bruise that continues to grow in size. It's not healing, or it's getting darker. That means that they're still bleeding under the skin, and so that needs to be taken care of and looked at. If they have a cut, so if they get a paper cut and it just won't stop bleeding, that's the time to give the doctor a call. More common for signs and symptoms of bleeding: coughing up or vomiting out blood in the urine or in the stools, whether it's the dark tarry stools for an upper GI bleed or the bright red stools for a lower GI bleed. All of those are concerning, and the patient needs to give their doctor a call right away. What we're trying to prevent is our clotting. So this is just a nice little reminder for our patients. What are our signs and symptoms of a clot based on where that clot is located? The first one is the arms and the legs for a blood clot that's not too life-threatening. Remind them that it's usually unilateral, or on one leg or the other, or one arm or the other. A lot of swelling, a lot of pain, redness, hot to the touch, that type of thing. That's a clot in our extremities. The more serious ones that we need to be concerned with, not that we don't want to be concerned with the other ones, but these are the ones that need to be taken action right away, are clots in our lungs, so our pulmonary embolisms, short of breath, difficulty swallowing, difficulty breathing, pain in the chest that's different than heart pain, that type of thing. And then also our stroke, so our our face, arm, speech difficulty, and time to call. So it's just a nice little reminder for our patients what to be looking for, and if their blood gets too thin or thick. The next one is a reminder about the different types of drug interactions. during cold and flu season and then during the summer with the allergies, what kind of medications are okay to take with their warfarin and which ones to need to be staying away from. It's nice, just a little reminder. These are more common of the prescription medications if the patient is prescribed a new medication. Remind the patient that if they are already on one of the medications on here, we will be taking into account that drug interaction. They may need more warfarin or they may need less warfarin than normal. But if they are on this medication and then they stop that medication during their warfarin therapy, they need to let their managing provider know, because that's when we need to keep a little bit closer eye on them. And then this is just a helpful hint of those foods. So I went and took and looked at all the resources that I showed you a couple slides back for patients to go look for, and it's just a nice list of the medications. Again, our higher concentration we're going to need to look more carefully with. Our medium concentration won't affect our iron as much. This is the same type of list, same foods, it's just giving them a better idea of what a serving is. So that is our warfarin teaching packet. The only two things out of those packets are the enrollment form and the checklist. Those are the only two that need to come back to the anticoagulation clinic. For the enrollment form and the checklist, just make sure that if you're outside the Lincoln campus and you don't have an anticoagulation clinic, to send those pieces of paper to medical records to be scanned and become part of the permanent medical history. So next we're going to talk about Apixaban or Eliquis. It's our first new agent. So Apixaban is a factor 10A inhibitor. That's where it works on the clotting cascade. What factor 10A helps generate is the thrombin. So that's what we're preventing. We're preventing thrombin from being made in these patients. This dosing is much more simple. You have a 2.5 or a 5 milligram tablet, and that's all you have to choose from, so which is nice. It's a lot easier dosing wise, and you don't have to play around with all the different color tablets. So I'm just showing you again where Eliquis is working, or Apixaban is working in the clotting cascade. So it's just cutting off that other half of the cascade. Not as many indications for Apixaban as for warfarin. It is used in our AFib population. Make sure that they're non-valvular AFib, and that's stroke prevention and other clotting thrombus event prevention. They do have the indication for both treatment and prevention of DVT or PE. So our dosing, again, is dependent on why are they using the medication, and also what else, if there's any renal adjustments. So most of the time you're going to see this used for AFib. That's the majority of our patients who are going to be on this, and that's 5 milligrams twice daily. It doesn't matter if they take it with or without food. It's pretty gentle on the stomach. Sometimes it's a little bit easier to associate taking the medication with breakfast and dinner, because most people eat both of those meals in a day. If the patient does have difficulty remembering, that's a nice little trick to help them remember. You can also use it for DVT-PE treatment, which is a higher dose, and then drop down to a lower dose. And then DVT-PE prophylaxis is at a lower dose than our AFibs. This medication does not have any hepatic adjustments, so the patient's liver function does not affect the metabolism or excretion of this medication, but their renal function does. So this is a medication that we need to make sure each year when we're refilling their prescription that we're looking at their kidney functions, making sure that we don't need to drop down to a lower dose. The nice thing with Apixaban is it can be used in the end-stage renal failure and also with patients on dialysis. So again, this should be no surprise, our main side effect for Apixaban is increased risk of bleed. The ones that are a little bit different here are rash, including anaphylactic type reactions. It is something that did happen in clinical trials, but the vast majority of patients are able to tolerate this medication just fine. They also saw some patients with hypotension. They're not really sure what the link between this medication and hypotension is, or if there is a correlation, but because it did happen in some of their patients, it is a reported side effect. Like I said, warfarin is the only medication with an antidote, so at this point in time there is no antidote to reverse the effects of Apixaban. If the patient is in a traumatic incident and needs care to prevent bleeding, massive bleeding, they can do symptomatic support with fresh frozen plasma and stuff like that, just to help get more of those clotting factors in that way. So this one, even though it's not warfarin, it doesn't interact with everything out there. There is still some drug interactions that we need to be aware of with Eliquis or Apixaban. Much shorter list, which is nice. And so the things that we need to remember that are kind of our big ones are our strong CYP3A4 inhibitors. You'll notice as we go on through this presentation that these medications keep coming up because they are so strong. They interact with all three of these medications. So our ketoconazole, our azole antifungals are our big ones. Some of our HIV medications as well. Our big antibiotic that interacts is chlorothromycin as well. So as we don't need to be as concerned with drug interactions with these medications, but we still need to make sure that our patients are safe while taking this. If the patient is prescribed this medication, it is recommended to decrease the amount of Eliquis given, the strength of Eliquis, to go down to the 2.5 because it will hang out in the body a lot longer. Strong inducers of CYP3A4 are another one that we need to be concerned about. So our rifampin, carbamazepine, phenytoin, phenobarbital, and St. John's wort. St. John's wort is a natural product and they can buy this over the counter, so sometimes we don't catch this one as often. But St. John's wort is one of those natural products that we do need to be concerned with because of all the drug interactions it has. If the patient is using one of these medications, it is recommended not to use Apixaban in them because they won't have enough in their system to cover them for those full 12 hours, and then so they'll be at higher risk for that stroke. Another one to just be aware of, there's no interactions or dosing adjustments that need to be done, but the patient should be aware that if they use the NSAIDs, so ibuprofen or naproxen, our SSRIs, so like Lexapro, and SNRIs, so like Cymbalta, if the patients are taking those medications, they just need to be aware that they are at an increased risk of bleeding, so they might notice that they're bruising a little bit more than if their friend who's also on one of these medications, because the serotonin affects our hemostasis as well, and our platelets, and the ability to bleed. This one does not have many food interactions, so that's the nice thing that the patients really enjoy, is they don't need to watch their diet. Alright, so like I said earlier, there is renal adjustments that need to be made. So while the patient's not coming in to see you once a month, they still need to have their blood drawn once a year. We just want to make sure that we are keeping an eye out on their CBC, their platelets, their kidney function, and their liver function as well. Usually if you have those results within 1 month of starting, that's good for baseline, and then in a year when they're asking for a refill, just make sure they've been updated as well. There's no routine anticoagulation monitoring required, so they take this medication and they're off on their way, and the only one that needs to be done is the kidney and renal. This medication is pretty expensive. It does cost around $350 per month, so that's a lot more than what warfarin, including the monthly testing, can cost the patient. These medications are covered by insurance. It just depends on the patient's insurance plan with how well they're covered. Currently, there's still usually a tier 3 for coverage, so it's going to be their higher branded copay. So some patients may not be able to afford this even with their insurance. So what is our difference? What's the difference between Apixaban and Warfarin? As you can see here, the time to peak for Apixaban is 3 to 4 hours. That's pretty quick, whereas Warfarin takes up to 4 to 7 days. And so that's why this medication, we start this medication and we can begin, we know that the patient is at their decreased risk for a stroke. And we don't need to bridge these patients with Lovenox when starting this medication. But because of this, the time to peak and then the offset, or the half-life, how long it takes to clear the body, is also relatively quick for a medication. It's 12 hours to clear the body for this medication. That's why we dose it twice a day. So if the patient misses a dose, they're going to be putting themselves at a lower coverage or a lower anticoagulation, which increases their risk at that point in time. Whereas if a patient missed a dose of Warfarin, they have a little bit longer coverage. It would take 3 to 4 days to start to see their INR go below their therapeutic range and start to lose that coverage and that safety net that the anticoagulants give us for that stroke risk. The nice thing is Apixaban is category B for pregnancy, so this would be something that would be safe to use in a pregnant mother. And you can see the difference of how they're metabolized. So our talking points with Eliquis. This is a twice a day food, so make sure that the patient knows that they're going to be getting 60 tablets every month, and it's really important to take it twice a day. It can be taken with or without food. It's pretty gentle on the stomach. They shouldn't notice any upset stomach or nausea after taking this medication. It is recommended to take it with a full glass of water. And then always, again, it's an anticoagulant. It's a higher risk medication, so they need to let their other healthcare professionals know, including their dentists. And then again, those common signs and symptoms of bleed. And so yes, I did make a cheat sheet packet for you for when you teach about Eliquis. The first stuff that I'm going to show you is going to be in all 3 of the newer agent educational packets. The first sheet is going to be another enrollment / checklist form. This is the only form that you'll send back to the anticoagulation clinic or off to medical records if you're outside of Lincoln. It gives you just choose which medication that you're educating about. Make sure that you give them the full packet. All this stuff will be included in each packet, so you just have to mark down and then talk to them about the med. These are a little bit quicker to teach about just because there's not as much drug and food interactions and lifestyle changes. Make sure that we're knowing if it's for AFib or for a clot, and then what their dose is. Again, the patient signs this form to show that we did do that education for them. The next thing is our signs and symptoms of bleeding and clotting. So again, this is going to be in every single packet because it is that important that the patient knows how to deal with the new increased risk of bleed and what are we trying to prevent. The next information is just going to be some stuff. You don't need to go over this information with them. It's just talking about AFib. The majority of our patients that we're going to be giving these packets to are for atrial fibrillation. If they're giving this packet because of a DVT, you can keep this little piece of paper in, but you can take these out because it doesn't relate to those patients. This little piece of paper will probably say DVT on it, but it's the website and the patient will choose DVT or atrial fibrillation. Very nicely done, patient-friendly language about the disease state. Can never have too much information on a disease state to make the patient prepared and understand what's going on with them. On the other side, you will notice that you are getting a yellow folder. Yellow folder is for Eliquis. That way you don't have to search through and try and figure out which folder is which. You just need to pick out the nice yellow folder for Eliquis. So we have two things on the Eliquis side. We have our cheat sheet for our medication with what the tablets look like. And so it just tells you what you need to tell a patient, and then signs and symptoms of when to be concerned. The nice thing with this is that it also goes over what Eliquis is and why they're taking it, super friendly patient language, but it also includes the coupon cards, both the 30-day free trial and if they are eligible for the reduced copayment for non-governmental insurance. So that's the nice thing, is that your coupon cards are included in there. So next we're going to talk about Rivaroxaban or Xarelto. This medication is also a factor 10A inhibitor as well, just like our Apixaban was. So it's preventing that formation of thrombin. This medication does come in 3 tablet sizes, and they're on the lower right hand corner of the screen. It comes in a 10, a 15, and our fun ninja throwing star 20 milligrams. That's probably my favorite medication out there. And again, just showing you the clotting pathway where this is affecting how the patient is becoming anticoagulated. So these are for Rivaroxaban, very similar indications to Apixaban, the stroke prophylaxis in our non-valvular AFib patients, also our prevention and treatment of DVTs. Whether it's the patient had a DVT and we're preventing another one, or we're preventing a DVT after surgery. Our dosing, again, is going to be off of indication and also depending on kidney or liver function. So our main dose that you're going to see is going to be our 20 milligrams for our AFib patients. This one is also nice because it's just a once-a-day dose. It's a lot easier for our patients to remember just to take the tablet 1 time a day. We recommend that they take it in the evening with their dinner or their largest meal because that's how it was studied, and so it shows that it's better to take it with a full meal for better absorption. For our DVT-PE treatment, it is a little bit lower of our dose, and then we drop we start with 15 milligrams twice daily, and then we drop down to 20 milligrams once daily. And then it also depends on, and that's for our treatment of DVT. And then our prophylaxis is a little bit lower than that. This medication is the one that we need to worry about our liver function, like I said earlier. And so there does have child PU classes recommendations whether it should be used or avoided. Again, there's renal dosing, so we're going to be looking out for our patients' kidneys once a year. This one, it is not recommended for patients who have poor kidney function. It does not have a dose for end-stage renal or for patients on dialysis. So our side effects. Surprise! Increased risk of bleeding. The other ones that they saw for this medication specifically is Stevens-Johnson syndrome. It's a pretty bad rash again, a lot of these are rare. Most patients are not going to experience these, but it is something to be on the lookout for if your patient's calling you saying, hey, this is what's going on, and you know that they just started this medication. Also syncope or dizziness. The hepatobiliary disorders, they've noticed that the gallbladder can be affected. Agranulocytosis and abdominal discomfort and pain. Again, there is no antidote to this medication, but you can use supportive care if the patient is bleeding and you need to give fresh frozen plasma. So our Rivaroxaban has drug interactions again, but also not as many as Warfarin. And so very similar to our Apixaban, our strong inhibitors of CYP3A4, not really recommended to use. So again, that's our antifungals, some of our HIV medications, and clarithromycin. They also have, they ask that you don't use it when fluconazole or erythromycin, which was not on our list earlier. Strong inhibitor or inducers, also not a good idea to use because it's not going to be in the body long enough. The other one, the new one here, is the ditalzam and verapamil, which you might be thinking, well, those are our heart medications and we use them in our AFib population. It's something that they've noticed that there's an increased risk of bleed when using these medications. So if the patient would be better off with this medication on board than without it, then they do say go ahead and use it when the risk versus the benefit outweighs the benefit. Or I lied, the benefit outweighs the risk. Again, NSAIDs and our other serotonin medications that affect our hemostasis can increase our risk of bleed. Don't need to stop this medication for those. Most of our food is fine with this medication, but there is a grapefruit juice and grapefruit interaction here, so just remind the patient that we want to limit our intake of grapefruit and grapefruit juice so that way they're better protected. Also, alcohol can affect the efficacy of this medication because it is alcohol affects how the liver works, and there is liver dosing that needs to be done. And it's always a better idea not to drink when you're on medication. So we do have some monitoring parameters. Again, we don't need to monitor our monthly INRs, but we do need to look out and monitor our CBC, our platelets, LFTs, and serum creatinine. Again, baseline and once a year when they're asking for refills. Now, do we need to draw them here at NHI? No. If the patient had recent lab work done at their primary care, that would be sufficient as well. The cost of this, again, is roughly the same as Apixaban. It's $344 per month. These are cash price. What I'm quoting to you is cash price, kind of an average depending on the different pharmacies. And that's for 20 milligrams for a count of 30. Again, this one is predominantly tier 3 for the insurance companies. So it just depends on the patient's specific insurance, which they can call and ask what their copay would be. So it's going to be a little bit more on the higher side for their insurances. So the difference between Rivaroxaban and Warfarin, what's going on here? So our time to peak, again, is a pretty quick onset. So once they start taking this medication, their risk is lowered pretty fast. The time for it to leave the body, or their half-life, is going to be 5 to 9 hours. Now you're thinking, I'm only taking it once a day, but it's leaving a little bit faster. And that's okay. That's how it stays in the body and how it affects where it's affecting in the clotting cascade. The patient is covered for that full 24 hours. But again, because it does have that shorter half-life, we need to make sure that the patient is doesn't miss a dose, so that way they're not putting themselves at a higher increased risk. This does have a time to hold before surgery, is about 1 day, unless they have renal function issues, then it's a little bit longer. This one's a little not as safe, but can be used in pregnancy as category C. So our talking points with Xarelto or Rivaroxaban. Again, once daily. That's a nice benefit to some of our patients who have trouble remembering to take their medications. They only have to remember to take it 1 time a day. And then this one needs to be taken with a full glass of water with their largest meal of the day, preferably their evening meal or their dinner. And then again, make sure all of their other healthcare providers are aware of that they're now starting this medication. Again, we have our nice folder, which is teal. I really wanted purple, but unfortunately Staples did not have purple. So this is our teal is for Xarelto. One side is going to be that same, all the information about AFib, and then the other side is going to be your Xarelto side. So you have your cheat sheet here about the medication specific, when to take it, different side effects to look for, when to contact the doctor. You also have your coupon cards, both your 30-day free trial and then the discount card for non-governmental insurances as well. And then I also provided a care path for Xarelto. They have a lot of great patient resources in here, and it just tells the patient more about the medication and also how to get connected with those patient services, including like refill reminders, which all companies have. So that's a nice thing. Next is going to be Dabigatran or Pradaxa. This is our last new medication. Dabigatran is a direct thrombin 2A inhibitor. So this is a little different than the last two medications we talked about. So if you look on our cladding cascade, it works a little bit farther down the chain. It inhibits both free and fibrin-bound thrombin, which affects that last part prior to all of our clotting factors being finished. This one is probably the simplest dosing of all. It's one dose no matter what the indication is. And as you can see here, it's a little bit shorter list for our indication. It's our stroke prophylaxis for our non-valvular AFib, and then also treatment of DVT, PE, or prophylaxis after an acute PE, DVT. It doesn't have that surgical prophylaxis indication like the other two. Again, one dose, 150 milligrams, twice a day, regardless of why you're using the medication. The only time that you would drop down is if they had poor kidney function. Then you would drop down to 75 milligrams twice a day. And there's no hepatic adjustments that need to be made. So our side effects: increased risk of bleeding. It's our last one, and then the big one here that the majority of our patients have stated that they have the biggest complaint for their side effect is the GI upset or the nausea. So it is now recommended that Dabigatran be taken with food to help prevent that stomach upset. They also have seen an increased risk of myocardial infarctions or MIs. They're not really sure what the link is with this. It's just something that they noticed in the trials. It could be where in the clotting cascade that it works, but they haven't decided where that link is. Also, thrombocytopenia is another one that we need to be concerned with. Again, no antidote that is currently on the market, but there is one in clinical trials right now for Dabigatran. So there may be one soon for Dabigatran to have a true antidote to it and no longer just symptomatic support. So our drug interactions, the new one here is our P-glycoprotein. It's just a way that our body metabolizes medications. It's a little different than our CYP3A4s. So it's just there are going to be a little bit different types of drug interactions with Dabigatran than there are with our other medications. Again, inducers, you'll receive these rifampin, carbamazepine, phenobarbital, and St. John's wort. Those medications kind of just hit all types of metabolism routes in our body. Inhibitors as well, ketoconazole or antifungals. These medications also work on all aspects of metabolism in our body. So if it's an inhibitor, a strong inhibitor of one or a strong inhibitor or inducer, you're most likely going to have an interaction. So I hope you at least are now aware of some of our big interacting medications. Also, again, NSAIDs and our serotonin products because of how they affect our hemostasis. The only food interaction that we have with Dabigatran is our grapefruit juice or our grapefruit So it should be done with caution. A lot of it is going to be large quantities, but we still, because of the type of medication this is, we don't really want to take a risk, so we would recommend that the patient try to avoid it if at all possible. So our monitoring parameters, again, it's our baseline and once yearly kidney function. You also would want to take a look at their CBC and platelets as well. You don't need to monitor their liver, but depending on the type of patient, it's probably a good idea to keep an eye out on that as well. The cost is around $350 per month for a 30-day supply. Again, it's a tier 3 usually for our insurance companies, but it just is going to be dependent on what insurance company the patient has for what their copay of this medication will be. So what's the difference between Dabigatran and Warfarin? This one is also going to be pretty rapid onset compared to our Warfarin. Food does affect it. So we would prefer that the patient take it on an empty stomach because it only takes an hour for the patient to be covered. But again, a lot of patients, or some patients do develop that stomach upset. So if they do feel nauseous after taking it with a meal isn't going to affect them too much. It delays it by an hour, so it's not too long of a delay. It is a quick offset again, or a half-life, 12 to 17 hours. So again, we're dosing this twice daily, and very important to make sure that the patient is taking this medication twice a day and not skipping doses. For this medication, depending on their kidney function is what we're going to depend on how long we're going to hold this medication. That is unique to Dabigatran. The other two medications, you don't necessarily have to look at kidney function for when deciding when to hold. This is also, again, pregnancy category C. So what are our talking points with Dabigatran? Our big one here is it's going to be taking twice a day, preferably with a meal, to help prevent that GI upset, making sure that they're taking it with a full glass of water. The unique thing here is that it does need to be stored in its original package that the patient gets it from the pharmacy, whether it be in a glass vial or a blister pack. The other two can be used and put into a pill container that the patient uses to organize their medications, but this one needs to stay in the original package until they're ready to take it. Swallow capsule whole. Do not break or chew or sprinkle the contents of the capsule onto other foods. And then this one is they need to discard any unused medications after 4 months. Typically they're given a 30 to 90 day supply, so it should they should have enough medication to get them through a 3-month supply. So hopefully they won't have any medication left after 4 months picking it up from the pharmacy, but if they do need to discard that because it won't be as effective and they won't have that coverage. And again, make sure everybody that is on their healthcare team knows that they're on this medication. We do have a handy dandy folder. This one is blue for Pradaxa. And again, you'll have all the AFib information, but you'll also have your cheat sheet for Pradaxa. It tells you right up top to make sure that they're taking it with food for a GI upset. And then you also have your coupon card for your Pradaxa. Pradaxa only has one coupon card available. So in summary, we've talked about 4 different types of anticoagulants. We did a brief review about Coumadin or Warfarin and how it works in the body and why we need to monitor it each month. And then we talked about each of the 3 new anticoagulants, Apixaban, Rivaroxaban, and Dabigatran. So our comparison, so what are our similarities between these 4 medications? All the medications can increase the patient's risk of bleeding because we are taking away some of their clotting factors. They all have different dosing strategies depending on what's going on with the patient, why they're using it, and physiologically what's going on with them. And they all have some sort of drug-drug interaction, so the patient needs to be aware of that and know that these can be dangerous medications if we're not careful with them. So what are our differences? Our differences are our cost. The newer agents are going to be more expensive because they are newer and they only come in brand name medication, whereas Warfarin's pretty cheap, even if we put into the cost of monthly testing. Our monitoring, routine monitoring with warfarin versus once a year monitoring with the new agents. Our food and drug interactions, where warfarin has a lot of dietary concerns and our new agents really don't have any concerns. Our varying degrees of drug interactions, where some have just those strong inhibitors and inducers affect them, where warfarin has pretty much everything can affect it. And then our differences is where do they work in our clotting cascade. That also makes a difference as to how the patient is protected. And then our antidote availability, where currently only warfarin has an antidote with the vitamin K and the prothrombin complexes as well, and our other ones are more of our supportive help. Thank you for listening.